So great to be here today. Thank you. I really kind of view myself as coming back to give you a progress report, because this whole thing I'm going to talk to you about started here 2 years ago, where I met Alan Roth, who is Jamaica Hospital, and Mike Tuggy, who many of you probably know, Jed Constance, who if you know Jed or not, and then which I say with great fondness, he just had his aortic valve replaced last week, so he couldn't be here today, or he would be here, and myself. So I'm going to give you, this is like speaking to the converted already. I'm not going to be trying to convert you, and I'll be racing through some things, but what I'm going to report to you on, and as kind of my accountability partners, is what happened a couple of years ago is that I was presenting the data analytics that I've worked with corporations, because my main job, Converging Health's main position is we work with corporations, get all of their claims data, all of their pharmacy data, their other demographic information, etc., and we put it into my kind of Converging Health's database, and then we do what I'm going to show you, which is restratify. And we end up with 4 quadrants, and the high risk, low cost quadrant are the unengaged. And so then we put programs around it. I have a program called My Personal Health Assistant that is just literally, if you took the doctor and the patient and you drew a line between, the personal health assistant is to equip the patient, and really the human being is the member, is what we would actually call them, equip them to actually be able to interact with the health system through 3 health literacies: health benefit literacy, healthcare system literacy, and health literacy. And in equipping them, when they walk in the room, they're like, here, I have 5 questions, I really want to know this, and we help them understand what's going on inside their body with the conditions they have and what's possible. And it's a breath of fresh air for the doctor to have a partner in health. And so that's called the My Personal Health Assistant. So a couple years ago, I'm here, I'm blah-blahing like I am now, about what we're doing. And Alan Roth was sitting in the audience, Jamaica Hospital, and he's like, oh my gosh, we've got all these programs for high-risk, high-cost people, or fairly for high-cost people. We have nothing for the right lower quadrant. We need to do something. So what I'm going to describe to you today is the journey we've been on since January 1st of this year, and the process we're taking them through, and to foreshadow. Basically, we've gone through a full assessment, collected their data. We have identified a clinic that has 4 providers that we're doing a pilot on, and we're starting the pilot now, and we're bringing additional resources in and transforming it. We're doing it concurrently with Wayne, who is working with Alan to bring an integrative health program on board and online at the same time. So that said, hang on to your bootstraps. We're gonna go through quickly. I love being around Wayne because he's a policy guy, and he, like the VA transformation thing he did. Oh my gosh, what a beautiful, beautiful piece of thinking and artwork. We're at the end of the spectrum. We're like literally walking through clinics, and by the way, Jamaica is about 70% Medicaid and Medicare dual eligibles, and then they've got Medicare, and then they've got a very small number of everybody else, right? So we're literally walking through clinics that were war zones during a lot of the time we were there, because we started working with them during COVID. And we're trying to create a new mindset, a new way of thinking in this group of providers, from the janitor to the top doc and administrators, to do things differently. So as you all can appreciate, in order to be successful, this is our simple change model. Let me see if I can get this to work. There we go. We've got to have a shared vision. We've got to have the skills, incentives, resources, action plan, and then we'll get results. And what we have gone through, the 3 of us, in every single one of these nests. Where do we have a shared vision? Where do we not? What skills are present or not? How are the incentives aligned? What are the resources and action plans? So I'm just going to walk through that as the outline. But to start off, we really went into the system, and I don't think Alan would be upset to say that it's really challenging, and it's not the most functional system at this moment in time. Otherwise, they wouldn't have us in, right? And so we have gone through and presented in grand rounds of things. What happens if you don't have a shared vision? It's chaos, it's confusion. And right now, to be frank, the people, the bean counters, who brought us in, by the way, so I say that with great affection, they have one vision, and the primary care doctors they're hiring have a very different one, and they have not been communicating. So I'll show you some things we have done to create the shared vision. The skills, and I'm talking about the skills that Wayne talked about with whole person health, the relationship-based way of thinking of things, are key. And if you don't have that, then everybody feels anxious. And that's what we have right now is the receptionists and the telephone folks and the social workers and the care coordinators and the actual people in the clinic taking care of people are all feeling this tremendous sense of burnout and anxiety because nobody's on the same page, and they don't have the right mindset to actually have that work. The incentives, one of the things that's crazy is they have 177,000 Medicaid lives that they have full risk on 177,000 Medicaid patients. Just think about that for a moment. But only 45,000 go to their clinics. All the rest go to IPA type related, where they have no authority over those doctors. So we're focusing on the 44,000 initially to try to get systems going. And the irony is that on the the other 130,000, they have a very rich incentive program for those doctors to behave well. On the 44,000, it's come to work, bust your ass, and you don't share any of the downside, upside risk. So that's a glaring problem. And plus, if you go down, that's the doctors. Then if you go down to the rest of the staff, there is nothing aligning their incentives financially, particularly around what they're doing, and there's no feedback on the non-financial things. So it's a very difficult place to really be able to express the reason you went into medicine. But I will tell you, that said, I have never been more inspired than to be walking through those clinics with these people who are in an absolute war zone, and they come to work every day, they risk their lives, and they have a deep passion, and they don't get paid. I mean, really, if you look at what they're able to pay in that part of the world, it's far less. That if I compare it to Dallas, Texas, where I live, and it's half what people get paid in Dallas, Texas, and they do it every day, and it's because of their passion, regardless of the system and how well the system's working for them. So what an inspirational group of human beings. But what that leads to is, why bother, right? If it's my passion, but I don't have the system to help me function, they leave. And unfortunately, they've lost a lot of fantastic providers and a lot of fantastic staff just because they're like, I can't overcome the system. So, and then the next is resources, and that is something that we're getting ready to bring in we've gotten the blessing of the leadership to bring in a MSW into our pilot program and physical therapy into our pilot program. Plus we're moving the call center they had this massive call center of a couple hundred people. We're pulling 4 people out of that and bringing them on site at the clinic, where when someone calls in, they can actually talk to the care team to see if they really need to physically come in. And then finally, if you don't have an action plan, then everything feels stuck. So we have gone through and assessed this, and I'm just going to run through this quickly. This is, hang on to your seat because we're going to go quickly. Everybody in the room could probably give this, but this is the grand rounds that we gave to the entire organization. That's what I'm sharing with you. So what is advanced primary care? And by the way, the title of our grand rounds is OPC, which is old primary care, to APC. And DPC for us is in the middle. DPC is people with the heart to take whole person care without the resources and the data analytics. And a lot of time in the common world, it's got a shroud of screw you. I'm an independent doctor, and you don't tell me what to do, and I'm tired of the current fee-for-service system, and there's kind of anger around it, and we don't want any part of that. We're building relationships, and we want to be very positive. So the title of this was OPC to APC. So comprehensive care, again, you all know this. I'm just going to read the top line. Patient-centered care. Wow, this is not moving the slides forward. There we go. Care management. Believe it or not, one of the most interesting things was we brought together the leader of the clinic with the leader of the care management team. They had 5 people assigned to our beta pilot site. the doctors and nurse practitioner and the person who ran the clinic, the operational leads, when we brought them into the same room, they're like, who are you? And they're like, oh, we're the care managers for your clinic. And they're like, no, we don't have care managers for our clinic. And they're like, yes, you do. And we introduced them and actually had them talk, and then we pulled up Epic, as stupid as it sounds. We pulled up Epic, and here we're in this section that the doctors never looked in, all these rich notes from the care management team, and the care management team was looking at their progress notes, but Mike Tuggy, I have to give him 100% of the credit for this, said, we're going to use there's a section of Epic, I'm not in Epic, but there's a section that where you have the diagnoses and you can put notes in underneath by diagnosis, and everybody sees that whenever you're in the system. It's kind of on your right bar. We're going to all start to use that. And they were like, oh, fantastic, we'll finally be able to communicate with each other. It was just, my heart broke that you had all of these people that weren't communicating, that care deeply, and the patients weren't winning. Accessible care, and this is where a lot of the things that with the group office visits, and one of the things we did, part of the bean counter versus clinician, is that the bean counter mentality was very fee-for-service, and I'll run through this in a sec, and the clinician was very patient care oriented. They were doing their math based on the number of people seen and the amount of billings, and we were like saying, you understand that you get paid whether you see people or not, right? I mean, this is full risk capitation. And what you're doing is you're filling the clinic up with what we will call the left lower quadrant at the moment, and there's no room for the people who really need to be seen. And so what the call center was doing was they were graded on how many appointments were seen every day. So if you called the call center and your doctor was booked, they would send you to another clinic. And so they were filling the schedule every day. They're like 90% capacity in patient seen, and probably 40% of the visits were worthless because the doctor's walking in, who are you? What do you want? And the person has been waiting in the waiting room for 2 hours because they've got clinicians that don't know who they are. So, that's why we're moving the call center into the center, and I'll go over that again in a second. Oh, man, I am not doing a good job here. And then quality and safety. All right, I'm taking too much time. So moving from OPC to APC. The big thing that we have to do is capture the minds of the providers that it's actually possible, because they're so cynical and so beat down. Susan Aran, who's here, she and I wrote this book called The Art of Medical Leadership, and and this is the story basically of how she and I took 510 doctors and did this transformation of their thinking, and once we got their thinking to transform, the system just took off, and I'll show you that here in just a minute. But she does does wonderful things with a number of physician communities around the country to help with this shift. So this is the conversation with the doctors about what do we need you to do, not what are you doing today. And this is kind of outlining why Wayne's programs are so important. So again, we use the same titles across the top, but this is, it's about you building trust with patients, encouraging patient input, encouraging team collaboration, holding the team accountable. And so it's a different mentality. And this is accountable, not controlling the team. There's a big distinction there. Care management, activate the team where appropriate, hand things off, give things away, but guide care, accessible care. Be willing to move from an in-person visit to a telemedicine visit to a video medicine visit. Just be flexible, just flow, and move through your patients. Match the need to their need, or match the modality to their need, and be accountable to the team to actually help the system run well, and then encourage proactive team involvement. So it's a completely different mindset from what they're doing right now, and you can imagine the responses we get, like, you're an idealist, this will never work. Now, are all of you familiar with this article that was in JAMA? I don't have time to go through it. Love to give you these slides, but bottom line is that this is basically Boeing, and it was a company that was just acquired by One Medical. It's an on-site clinic company that is now doing a lot of Medicare risk. Iora Health.
Oh, yeah.
So this is a study using their clinic. Bottom line, 23.5 commercial patients. They had the ones that were using the advanced primary care clinic and the ones that didn't at all, and they compared that to a community match control. And again, we're going to start here. This is utilization. Primary care utilization went up, specialist mental went down, mental health up. Physical therapy was pretty much the same, a little bit down actually. Drug, surgery, laboratory, radiology, emergency room visit, and hospital. And this is the answer to your question. This is how for-profits can make a fortune, is because you actually right-size care. And here's the dollars of it. So now let's do this. You spend a lot more, 100% more on primary care, doubles the amount of resources put into primary care. You see the specialists goes down dramatically, mental health goes up, physical therapy goes up, prescriptions, and a lot of this is inappropriate prescription cost because we're talking about money. It's not adherence and compliance and medical possession ratio. It's inappropriate cost from prescriptions. Drug administration, surgery, lab, radiology, guess what? Hospital emergency go down. So stunningly, in this particular Iora instance with Boeing, what they found was that if the members used the on-site near-site versus the other, costs went down 45%. And that is $146 per member per month. That is a lot of daggone money, right? And I'll come back to what that means for Jamaica in a minute. Now, I'm not that good, and this is Susan Aran and me doing the same thing. I started with a company called Medical Edge in 2006. We had 1.3 million patients, 400,000 commercially insured lives on Blue Cross Blue Shield. I'll tell you why that's important in a minute. 25,000 full risk Medicare lives, 343 primary care providers, 182 offices. 4 years later, working with Susan, this was 510 providers with 240 offices. And I was the chief medical and strategy officer. She was the vice president in charge of learning and development. Is that correct? Is that the right way to say that?
Leadership development.
Say again?
VP of leadership.
Leadership, okay. So that's what led, this is our story of our journey through this. But to make a long story very short, the first thing I had to do was to build an IT system that would actually have the information in front of the provider at the right time, and the care team communicating at the right time. We spent a couple $1 million on that. It took us 2 years. And we called ourselves the Health Star Alliance, being modest as we are in Texas. And then we started to give the physicians their feedback. And this particular one, we use BTE, it's no longer existing, but anyway, this is the cardiac care. And we had the actual outcome-based measures as well as some process-based measures. And this is what I really want you to focus on right here, and that is how well they were performing. So May 8th of 2018, we turned this on and gave it to every doctor. There was a primordial scream. What bullshit? What bullshit? I am so much better than that. Who the hell do you think you are telling me that's the quality of my medical practice? And man, my phone was going off. And I said, well, just go over here and click on this button and see if they're actually your patients. So they went over, they clicked on it, it's like, well, that's Betty, her husband has cancer, you can't expect her to go to the pharmacy and get her blood pressure medicine. I'm like, yeah, I kind of can. Or we need to bring the medicine to her, let's figure that out. And they went through the list, and at the end it was like the big mouth frog joke, right? You know, the big mouth frog's on the lake, and she has a baby, and so she goes over to the stork and says, what do you feed your baby? And the stork says, fish, minnows, will be fine. Oh, thank you very much. Goes over to the turtle and says, what do you feed your baby? And the turtle says, well, we chew the muck and we catch some of the fish and so forth. Oh, thank you very much. Goes over to the alligator and says, what do you feed your baby? And the alligator says, big mouth frog. And she says, oh, thank you very much. Right? That's kind of what we got. And but then the doctors felt a sense of shame, which was not what we intended. And that's again where this mindset change that Susan works on is so important, because they become kind of self-destructive at that moment, and they just work harder. I will make this work. I will fix this problem. And you can see nothing got better. But then, particularly Susan had a conversation with them, well, what if you actually brought your team in? What could you do with your team? And so then there's this like autocratic shift where it's, you're going to do this, and you're going to do that, and you're going to do this, and don't forget to do that, and by God, you didn't do that yesterday, what the hell's your problem? Right? And there's this like that comes out, the monster inside us. And as you can see, it did not make a difference. So finally, I have to give Susan all the credit for this, to go from a control mindset to an influence mindset, from a boss, a cowboy who's going to make things work, to the leader of a ship or captain of a ship mentality. We saw this big change, and basically the doctors handed it off to their staff and said, you do it. I am here to support you, but you start to do this and I will support you, which was a huge step. But look what happened. And within 24 months, there were 163 doctors who had BTE recognitions in multiple areas. And they were taking an extra half day off. And most of them, this is a fee-for-service environment, don't forget that, most of them were making 25% more money. Because we had risk contracts, but mainly because we were doing all the preventive services that we never had time before. And you get paid for preventive service and fee-for-service, right? So this was a huge mind shift, and to me, this is the turning point of my life, because I really got how dysfunctional and wrong the system was we had, and we could do it a better way. And it just inspired me in my life. And again, Susan inspired me that it could happen, but it was more Susan than it was me. It was more a mind shift change than it was be a better doctor. The result for us was not $140, it was $17 per member per month. But when you have 400,000 Blue Cross Blue Shield people coming to your clinics every day, that's $5.4 million a month. So Eduardo Sanchez, the leader of Blue Cross Blue Shield North Texas, called me up and was like, what the hell are you doing, dude? We love you, because if we send our people to you that are full risk, we're making a fortune off you guys. So he kindly gave us a $345,000 bonus that year. I was like, thanks, Eduardo. But anyway, on the Medicare side, we did much, much better. And for people with diabetes, it was $120 per member per month, so much better. All right, so what we did to start off with is we went into the doctors and we had a conversation with them, right? What percentage of your time are you trying to do something that someone else could do just as well? How much of your day would you like to delegate? How much of your day are you using your skills and experience to make a difference? They all feel like secretaries, is what they feel like, to be honest, in the fee-for-service mess they've got. How frustrated are you with the system around you? If everyone from the receptionist to specialist offices were aligned, how much more productive could you be? And what percentage of your patients do you think you have a negative outcome? As you can imagine, we scheduled a half hour to talk to the doctors. 2 hours later, we're like, dude, you got to go see patients. They were so cathartic, their frustration and their emotional energy, but it got them on board quickly. So advanced primary care Jamaica style, and I won't go through this because this is really the steps that we've got to do, but we were teaching them what we need to have as a vision. All right, skills. Team-based care skills. What does a medical doctor do? What does the PA nurse practitioner do, right? How are they different? What does a nurse do? And this is where there's a gasp, right? Well, wait, we don't have systems. You know, the doctor's mentality is if you want it done right, you have to do it yourself. That's the fee-for-service mentality, because they've tried to hand things off and people have died, right? That's a pretty negative feedback loop. So when we start talking about your nurse and MA and what they're going to be doing, and your office staff and what they're going to be doing, and the skills they have to have, then there's this great big, we can't do that. But what we have found is if we build these skills in these people and they build the trust of the doctor, they'll slowly be willing to release their grip. And that's a process that takes 18 months. That was the process that I showed in that other slide where you saw the proficiency go up over 18 months. So we have now started this journey at Jamaica. So aligned incentives, this comes back to, oh my gosh, what our deal is with the bean counters, which again I say with great affection, is we're going to create money and you agree to spend that on the primary care until we get that to be a functional team. We're not going to ask for anything more than a social worker and a physical therapist. And then on the call center, as you lose people over there, they quit, which they have a very high turnover. We're just going to move 4 of them over here. So there's no new budget there. And so we will create the aligned incentives. We will create the savings, because I have all the data. we actually know what the revenue and the costs are, we'll create the savings pool that we will then start to reinvest to do this pilot and bring it to your entire group of clinics. And that's here's the grid, here's the money grid. We have this clinical risk score that I'll go over in a moment, but basically it puts people in 4 categories, right? Low risk, low cost, these are the healthy, keep them healthy. Immunizations, annual exams, preventive screenings, this is relationship building as much as it is medical practice. But those folks, they have pregnancies, appendectomies, gallbladder, gallbladder attacks, accidents, they go to the emergency room for panic attacks, whatever, and their spend jumps up. So 55% of members, 1 to 2% of members, 4% spend, 6% of spend. So this is 57, 58%, and unfortunately these people are the ones that they just jam into the clinics and they fill the clinics. Because these folks, the high risk, low cost, no, that means I'm supposed to be done. Lord, I went as fast as I can, I'm still not done. All right, so these are high risk, and we've got to get them into primary care. This is where the primary care has got to shine. They have metabolic syndrome, hypertension, diabetes, they're developing plaque, anxiety, depression, they've got stage 1, 2 cancer, it's not being discovered, and boom, they go up into the high risk, high cost. This is 8% of your members, 80% of your spend, right? Heart attack, stroke, cancer, substance abuse, inpatient mental health, musculoskeletal surgery. About 70% of the people who go from high risk, low cost to high risk, high cost didn't have to be there if they'd gotten great primary care. 60% of the people in the high risk, high cost in a commercial population, I'm not talking about your ChenMed population, next year will no longer be in that quadrant. They will be dead, retired, on disability, or they've had their heart attack, they spent $150,000 or $50,000 to $150,000, and now they're back down here, $3,500 going to the primary care doctor to get meds and a cardiologist once a year to get checked out. So if you're ever going to get ahead of disease, this is where you have to be. And if I walked up to the people in this quadrant and I said, how do you feel? What are they going to say? They've got stage 2 colon cancer. I feel fine. They're 30 seconds away from the plaque rupturing. I feel fine, right? They've got, they feel they've got some depression. Well, this is what happens when you age, right? They do not understand their risk, and this is where the health literacy of that group is the determinant. So this is the specialists and facilities. 10% of the people, 90% of the folks need to be down here, primary mental health care, prevention pathways. And the bean counters got that. They were like, we have got to reinvent our system. And they gave us this pilot. All right, so our risk score has 3 components. Absolute risk, the medical condition, the complexity of their care, and the toxicity of their care, like how dangerous it is to them to be that. And sometimes it's necessary to take toxic drugs and things, but we can't change that. Like, I can't go in there and say, I'm going to undiagnose you with rheumatoid arthritis. I'm going to undo your cancer. Second, though, is that how's the health care system doing for them? And we all know about gaps in care. We took major medical conditions, whether it's musculoskeletal, cancer, diabetes, hypertension, cholesterol, cardiometabolic, and we went through, okay, stage 0s, they don't have disease. Stage 1, pre-disease. Stage 2, disease. Stage 3 is disease with complications, And what should stage 1 people be receiving? 2 receiving, 3 receiving, and then we take the data and we look at that and see if they're receiving it. So it's similar to gaps in care, but it's much more specific. We look at the appropriateness of interventions that they're getting, which in fee-for-service, oh my gosh. And then we look at the cost of care. And as stupid as it is, you could take in medications, if you just took people and got them filling their medications at the right pharmacies, you can reduce 10 to 15% of cost. So it doesn't have to be profound, and it can be generics, believe it or not, that you could save a lot of money on that. And for the patient, because most of the commercial insurance, it's high deductible health plans, which is a joke. The healthcare system utilization, though, is the individual's choices. What do they do when they have a problem? And so often, I think we look at the absolute risk and we do the MERA score, the Johns Hopkins, score, and this is taken into consideration, but we don't hold the person responsible for what the choices they make when they have an issue. And that's what the MyPHA program is, right? Where are you getting care? We look at new diagnoses. Where was that diagnosis made? Emergency room, hospital, urgent care center, or with their primary care doctor or specialist. The primary care utilization, we have a formula. Given this, how often do you need to see a primary care doc? And if they don't see them that frequently, we consider that a utilization problem. And then we've got, adherence, compliance with medications and care. So all of these things come through. There are 350 variables, and every person gets a score. But it's a whole person score. It's not a Z-specific score, which I think is a huge mistake. All right, so there you go. So here's Jamaica, and I'm over time. That's killing me. So Jamaica has 14,000. This is just the people that we're going to try to manage. 14,000 people in low risk, low cost. $525 per year is what's being spent on them. That's 10% of their spend. Boom. Very small number, surprisingly, of the low risk people. That's because there aren't many low risk people necessarily that are in this. About $12,000, 2% of the total spend. 1% of their members are popping up here and coming back down. The money quadrant for us is 8,536 members. That's 33% spending $1,514. That's 17% of their spend, which is actually higher than most commercial populations. But bam, they spend 70% of their money on 10% of their population, $21,000 per person. We're going to turn these people over. Those are people that are in specialists and facilities. As they regress to the mean, we're going to catch them and pull them back in. But we're not spending a lot of energy here. We're building the system to manage these people. And this is the old thinking, fee for service, right? And number of patients, this is the bean counter. Number of patients, percent of schedule filled, number of calls made, numbers of appointments, number of orthopedic surgeries, number of patients reached for care coordination, CPT coding bills sent, total billing, number of charts closed in a 24-hour period, the number of admissions. So this is what got them all excited, and we're like, dude, that is 20th century thinking. You've got to move, and move to the health risk of your members. High risk member engagement, HCC scores, patient experience and loyalty, because they have leakage into Albert Einstein and other places. Members assessed for risk, their literacy of their population, and this is the integrative medicine that Wayne's bringing in and we're going to need to really lean on. Team member satisfaction, pathways of care, compliance, and then their number on their forward contract is what they call EMR, which is something, I don't know, it's a surplus medicine is what the private, the non-for-profit, they call it a surplus, not a profit. So, and this is the whole point of they're filling their clinics with the worried well instead of the high risk, and we gave examples of that. East New York is what we're doing this on. We have got workflows and scheduling, call management, team coordination, training, compensation. What am I doing wrong? I think I'm an idiot. I can't get it to move forward. Could you push the button, please? Clinical protocol development, epic maximization, and specialist integration. So these are our workflows that we will be working on. And we've got a whole data side, that's me, where we're going to look at the revenue in, we're going to look at the engagement by risk quadrant, services provided, how they interact with people, and who on the team interacts with them, their patient experience, and we're going to use EPS survey and the HQIP metrics, which is, blah, blah, blah. And probably you have to put up with that crap all the time. So we've got the data that we're going to be pushing back to the teams and of course, leakage. So I won't waste your time, but this is what we are doing. This is the timeline for 22. Please feel free, yeah. I just keep filling it in. And we've got a whole plan on how we're doing that. I'm doing the data dashboard creation for everybody, and then we're going to be socializing these things and keeping them up to speed with where we are. Next slide. And we're going to use the data to do the outreach. Right now, we deliver the risk stratification information to Jamaica on a monthly basis. They take the high-risk patients and they reach out to them. And they're pulling them into the clinic. We're filling the clinic. We did 14 patients a day is the most that a person can go into their day with until 3 o'clock the previous afternoon. And we're keeping the other visits open and so forth. So go ahead and just fill this out. Yep, and hit the, you're going to have to keep going for it. So this is saying they brought in family doctors to do this. They didn't bring in, actually, it's so funny, they brought in PwC to do this same assessment, and PwC's conclusion was, you need to see more people in your clinics and need to increase your volume to get to profitability. And of course Alan Roth, who's there, said that's just crap. That's the wrong thing. And so that never went anywhere. And then they brought us in as a result of this meeting. So I just really want to acknowledge you, Larry. Without you, none of this would have happened. And I think this is going to turn out to be a wonderful demonstration of what's possible. And we're going to get the results. And this, again, talking to the doctors, what this means for you is your efforts will feel more meaningful. Jamaica is putting resources in place for you, so don't leave because you're dissatisfied or frustrated or burned out. Data is being analyzed and brought to you. Epic is being evaluated, and we're making it better for your workflow. And more resources, revenue, and aligned incentives will occur as we see success. What it doesn't mean is extra work, more documentation, longer hours, more time spent working alone on your computer trying to get your charts done within 24 hours, more demands on you for administrative work, which they feel like secretaries. You to have to tell others to track what others on the team are doing. That is not what this is. So we're capturing the heart of the physicians, and then we're going to have Susan come in and help us transform their thinking. And the implications are, if we're only successful, as I was at Medical Edge, that's $8 million a year more. If we actually could achieve what they did in the study, that's $70 million or $6 million a month. So that gets the bean counters on our side, and it's going to be a tough journey, but we're very excited about being able to tackle it. So I want to thank you all. Namaste. I'm going to run to the airport. I have to take off. But